Good morning, everyone. It's my pleasure to welcome you to the Friday morning academic meeting for the Department of Internal Medicine at Charlotte Macheca Johannesburg Academic Hospital. I'm Georgia Demetriou. I'm the Academic Head of Medical Oncology for the University of the Witwatersrand. We're going to have a very interesting talk this morning from Dr. Karishma Singh, a fellow in the Department of Medical Oncology. The discussion today will be about an approach to oncological acute medicine and the oncological medical emergencies. We really do feel that this has got something for every physician. It's something you'll all be faced with. Not only is it going to address some of the consequences of our chemotherapeutic agents, but also some of the consequences of the disease itself. There's no one better to take us through this than Dr. Karishma Singh, who has spent a significant amount of time in acute care medicine and in ICU scenario over the last 2 years. So I'll hand over to you, Karishma, to take us through the topic. Thank you.
Thanks. I hope everyone can see my presentation.
Yes, we can see it.
Thanks very much, Prof, for that introduction. Hopefully I can do justice to this topic. It's incredibly broad, but we're going to focus on a few areas. So thanks very much for the opportunity. So why this topic? We have to ask ourselves, why are we even discussing this topic? Does an oncology patient ever warrant ICU? Does an oncology patient ever have a good prognosis? Should we resuscitate an oncology patient? And the answer to these questions is actually maybe, and we have to look at our patients specifically. There's been a paradigm shift in terms of oncology and critical care medicine towards precision medicine. That means focusing your therapies on the actual patient. So it's not going to be a broad answer that all oncology patients have a poor prognosis, metastatic cancers associated with a poor outcome. We have to look at the patient characteristics, the cancer characteristics, and take it from there. So essentially, what are the aims of an acute oncology service? That is part of what we provide at Charlotte. It encompasses all of these features. So dealing with patients with acute complications from their diagnosis, assisting with the diagnostic process, patients with oncological emergencies, which is what we'll be focusing on in this talk, and obviously the supportive care associated with patient treatment and complications of therapy, as well as at end of life. So we're still going to support our patients even when they reach the palliative scenario. We also try to limit the time that a cancer patient spends as an inpatient, because that we know is associated with a poor prognosis. We're trying to get patients home to spend time with their families. So the guiding principles in oncological emergencies, we're still going to pay attention to the principles of oncology, which is appropriate diagnostic and therapeutic principles, appropriate blood investigations, appropriate imaging, and of course your histological diagnosis, your grading. So tissue is king in oncology. We always need a tissue diagnosis. It doesn't matter what the emergency is. We need to know what the cancer is. We need to stage our patients appropriately. And then we need to, very importantly, look at the performance status of the patient. We also need to look at our therapy goals of the patient. Are we being curative? Are we being palliative? What are the patient's wishes in terms of their therapy goals? And very importantly, you're going to hear me saying it again and again, recognize problems early, intervene early in these patients. So this is the ECOG scale. It's a very, the Eastern Cooperative Oncology Group scale. It's a very simple scale that we use in oncology to classify patients in terms of performance status. Oncology patients, without a doubt, are severely ill. They can be very severely ill. They can have multiple comorbidities. So it's a very important concept to decide whether or not the cancer is causing a patient to have a poor performance status, or if the patient themselves has a poor performance status. And sometimes it can be difficult to tease that out. So we have to closely examine our patients, involve a multidisciplinary team, get different opinions. But obviously, if your performance status is going to be related to the patient condition, therapy for that patient is going to help them. There's multiple reasons why an oncology patient would have severe disease. Side effects of the chemotherapy, immune function and dysfunction related to the malignancy itself. We all know that tumor immunology plays a big role in cancer. So that's very important, as well as the comorbid disease and the age. So I put an asterisk next to age because unfortunately, cancer patients are getting younger. and they're also getting older because therapies are improving and they're living longer. So that's a very important consideration. We need to be quite cognizant of all of these factors. So just a quick graph. Unfortunately, this is cancer in America, which is a developed country. They have access to therapies we may not have, and obviously our population presents very delayed in their, generally quite delayed in their course of illness. But this is just to briefly show that cancer death rates, by and large, except really for pancreas, are decreasing significantly. So cancer is going to be a problem that we face in medical practice, regardless of what specialty you pick. There's many new oncological specialties emerging: neuro-oncology, cardio-oncology, nephro-oncology, psycho-oncology, acute oncology. So there's really no way to avoid oncology, essentially, in medical practice. So curable cancers. So again, there is always a asterisk to these diagnoses. The time of the presentation matters. Early is always better. So essentially your breast cancer, your germ cell tumors, your acute leukemias, early presentation of melanoma, cervical cancer, colorectal cancer, prostate cancer can all be cured. However, again, it depends on your patient. So even if you have somebody who's a first-line metastatic breast cancer, a luminal A breast cancer, it doesn't mean that that patient doesn't have multiple lines of therapy to go and can still have a very good outcome. So it doesn't mean if that patient presents, for instance, with a community-acquired pneumonia, you shouldn't give them a chance to go to ICU. So it's very important to look at the patient and look at the diagnosis. There's many cancers we have a lot of therapy for, and we can actually, the patient has quite a reasonable life expectancy and a good quality of life. So it's very important to look at your patient and the actual diagnosis. So assessing and recognizing an acutely ill oncology patient. The typical danger signs may be masked by therapy. Neutropenic patients will not have the same manifestations, as they may not be able to mount an immunological response. You've got to take patients' symptoms very seriously. And you've got to remember the patient is actually the expert of their diagnosis as well. They know how they feel, how they respond to chemotherapy, how they've been feeling with their cancer. So a very big warning sign is an acute change in mental or neurological status. And a change in respiratory status is also something we have to pay close attention to, needing critical care intervention. You have to have a high index of suspicion, and it's very important to take a history of the therapy also to give you clues to diagnosis. So oncological emergencies, as we've mentioned, can be a spectrum of emergencies related to the primary diagnosis, related to the metastases, the chemo and radiotherapy, and the underlying comorbidities. Risk stratification for the escalation of care. So I've alluded to all of these factors. The cancer characteristics. Are you curative? Are you palliative? Do you have a palliative cancer, but with many treatment options left, so you still have a reasonable life expectancy? Your patient characteristics, your therapy characteristics, and the time causing your disease. And very important, you're going to hear me say time and time again, a multidisciplinary team. So we need the radiation oncologist, the medical oncologist, critical care staff, the general physician, the surgeons, whomever you need to involve them early. So the classical oncological emergencies, neutropenic sepsis, malignant hypercalcemia. So I'll be touching on all of these as well as a few others while I go through the talk. So the other emergencies which are related to cancer, this is just an endless list. It can be anything: neurological, intracranial hemorrhage, status epilepticus, pericardial effusions, massive pleural effusions, abdominal bowel obstruction, cholangitis. So you really have to have a high index of suspicion. You've got to suspect everything, have a broad differential. Cancer patients can be very sick due to their and related to their cancer. So the first case, I'm just going to have a few clinical vignettes that go quickly based on actual cases that we've seen in our hospital, in our critical care unit, in our oncology unit. So this was a gentleman with a neuroendocrine tumor of the lung. He presented essentially in extremis, found cyanosed in the tripod position when the ICU team was called to assess the patient. He actually had a fairly good outcome. He eventually succumbed, unfortunately, to a pulmonary embolism, but he was successfully extubated. He had an MDT approach, so he basically had a large mass, which was below the carina, compressing the trachea. He then had an emergency airway secured in theater with the help of cardiothoracic and rigid bronchoscopy, and he did very well. initially, of course. So what is malignant central airway obstruction? So it's quite self-explanatory from the term. It's any malignant mechanical obstructive process that impedes the airflow within the central airways. So obviously we understand that patients that may present like this could possibly do badly. It's associated with CA lung, but we have to recognize the syndrome because it could essentially lead to a death from painful suffocation. And we really need to ensure that a patient receives appropriate palliative therapy as well. It is appropriate in this case to be aggressive in our supportive care because we're trying to alleviate pain and suffering in our patients. And actually with multimodal therapies, the patients can actually do well, and we're able to secure airways on them and alleviate their suffering. So the causes, as we've mentioned, lung malignancy being primary, especially non-small cell cancer of the lung, neuroendocrine cancer of the lung as well, lymphoma, which is obviously a curative diagnosis, hence tissue is always important. Anaplastic T-cell lymphoma can cause both an airway obstruction. It can also cause supravenacaval syndrome, which we're going to discuss next. So that is actually, I know when we hear the word anaplastic, we think that the patient's going to do badly, especially if we have ALK positive disease, which is a specific marker on the tumor cells. Patients actually do very well, and they generally tend to be young patients, and they respond well to CHOP. So it's not, again, discuss the patient early with an MDT. Just these diagrams, I think, are fairly self-explanatory in terms of stenosis and how the tumor, so it can be endoluminal, extraluminal, or mixed picture. So again, briefly touching on the management, you have to obviously image the patient appropriately, do appropriate diagnostic tests. Your goals of therapy would be supportive in maintaining a patent airway, oxygenating the patient, ensuring their comfort, and then you treat appropriately depending on the type of malignancy you have. If you have a curative intent, you can obviously consider surgical management as well as stenting, then going to a definitive chemoradiation management as well. So the superior vena cava syndrome, I'm referring just to the malignant syndrome here. Obviously, there's other causes of superior vena cava syndrome, which are non-malignant, but this is also a very common presenting feature of malignancy, again, causing a lot of morbidity in our patients. And also can occur in malignancy when you put a CVC into a patient and they have a very high risk of venous thrombosis related to the indwelling device. In terms of the signs and symptoms, we've all seen this patient with a very red face, out of keeping with the rest of the color of their body, collateral circulation on the chest wall. They can have edema, proptosis, cyanosis, plethora, and it can go all the way up to, in terms of the grading system, to death. So the management principles, again, they're going to be very similar in a lot of these emergencies. The goals of care are to ensure the patient comfort, ensure oxygenation, ensure a patent airway, and these are difficult, tricky airways. The central airway obstruction being the same. You need to call for expert help, be it from anesthesia, cardiothoracics, ENT. Recognize the problem early. You don't want to be dealing with this airway at 3 a.m. by yourself in the ward. It's going to obviously end poorly for you and the patient. Obviously, you would image the patient appropriately, and you're going to consider anticoagulation. So in our center, we do have access to endovascular therapy. We can do venography, and vascular team can assist you with actually opening the vessel with endovascular techniques. And you would obviously treat the underlying malignancy once you've secured an airway and assess the patient going forward as such. So this is just another brief and very common clinical vignette that we see. This patient came to clinic. She was a newly diagnosed, essentially triple negative breast cancer. As you can see, a Chi-67 of 80%, which is very, very aggressive tumor. The patient had multiple red flags when we were examining her and taking a history. She had severe pain. She was admitted in hospital for a week in December. Still wasn't resolving. She was just so uncomfortable sitting in the clinic. The pain was radiating down the leg. It wasn't responding to morphine therapy. She also complained of constipation. So eventually we were able to manage the patient urgently on the same day, and we found that she had multi-level T-spine disease with osteoblastic mets and spinal cord compression. So she received RT to the spine. She coped very well. Her pain was much improved. She was completely mobile, bladder and bowel function, which was saved, and she will continue with her palliative chemo at the oncology clinic. So spinal cord compression, it occurs in up to 6% of all cancers. It can theoretically occur in all cancers, commonly breast, prostate, lung cancer, multiple myeloma, as we know, and non-Hodgkin's lymphoma as well. So the pathophysiology is related to the excellent vascular supply of the spinal cord and the bony column. And with the pelvic tumors, it's related to the venous drainage of Batson's venous plexus. So essentially, the tumor grows from the epidural space, taking the path of least resistance and encircles the thecal sac. So eventually, if you don't treat the patient, it's going to lead to spinal cord infarction. And steroids may assist with the vasogenic edema. That's the rationale for giving the steroids in these cases. So the red flags, very important to recognize. So you can't just ignore the patient's pain. If the patient is telling you, I'm in agony, I can't lie flat, they complain of a band-like pain, you've got to take them seriously. And it's very important that we always say, oh, the bladder and bowel is fine, well, you know, it's just pain. That's a late sign. It can be something as subtle as constipation, urinary retention. So it's very important to take these patients seriously, because if you lose neurological function, that's quite catastrophic for the patient. The thoracic spine is a commonly affected area, followed by the L spine. And obviously, it's more common in patients where you know that they have bone mets, like someone like prostate, who commonly presents to oncology with bone mets, or referred when they get bone mets and a high tumor burden. So this is just a quick reminder of the spinal cord levels and your examination findings. Obviously, you're going to get pain, you can get a radiculopathy, you can get instability and loss of function. So the aim is really to try and save as much neurological function as is possible for the patient, because it really greatly changes the course of the patient's life and their functional status. If somebody is now bedbound in a nappy, obviously you can't really offer that patient much therapy, and changes the ECOG could be from 1 to 4. So it's really, really important to advocate for these patients, image them early and treat them early and recognize them early. So these are just some grading scales based on the imaging findings that are used. So it's the ESCC grading scale of severity of the spinal cord compression. So in terms of management algorithms, this is with multiple myeloma, but it's quite a nice, simple schema of how to manage the patient. If they have neurological patients, you take neurological symptoms in your patient, you take them seriously, you give them glucocorticoid therapy always. You'd assess the spinal instability on imaging, and you would then obviously refer appropriately. Usually our radiotherapy or our radio-oncology colleagues are involved in the management of these patients, but you obviously also need to consult your orthopedic spine unit. So spinal stabilization is definitely an option in these patients. We can't just say, oh, they have cancer, we're not going to take care of their spinal cord pathology or their bony pathology. They are definitely candidates for those to be sorted out as well. So brain mets as well, I just wanted to touch on briefly because it's such a common comorbidity. So it's a 32-year-old female, another patient that presented to us. Essentially, she presented with status epilepticus. As we know, she had a very good prognostic cancer, so luminal A breast cancer, which means that it has a Ki-67 of less than 14 to 20%, depending on which classification system we use. So this patient, again, had a multidisciplinary team approach. ICU was consulted, neurosurgery was consulted. She had drainage of her system, of her CSF system. She was taken to ICU post-op, treated by the radio-oncologist, able to achieve seizure control, and now is discharged home and continuing rehab. So they're the most common intracranial tumors in adults. Obviously, I'm not taking into account primary brain cancers. I'm talking specifically about secondary cancers, which go to the brain. Most commonly lung, again, breast, melanoma, papillary thyroid cancer, another cancer which is associated with a good prognosis. Papillary thyroid cancer, melanoma, renal cell, tend to cause hemorrhagic mets. So essentially, the pathophysiology is related to the primary tumor gaining access to the blood-brain barrier and then invading the central nervous system and proliferating there. As you can see, just a pie diagram of the specific cancers, as we mentioned, lung cancer being a very big part of it. So the management algorithm, again, focuses, as we mentioned before, on surgical resection, which is definitely a possibility if you have access to your neurosurgical team, a multidisciplinary approach, Again, our radiation oncology colleagues are very involved in the management of this condition with the stereotactic therapies, which can do very, very well, specifically targeted to the patients, as well as radiosurgery with gamma knife, and obviously whole brain radiation. The next complication I'd like to discuss is hyperviscosity secondary to monoclonal proteins. So hyperviscosity refers to any change in your blood constituents, be it your protein, your plasma proteins, or your actual cells. This patient was an elderly female who presented with delirium. The red flag here was the failure for the chemistry blood test to be processed. So every time there was a UNE sent off, it was essentially unable to be processed. And basically the patient was then referred to the hem-onc team and a diagnosis of hyperviscosity was made. She had Waldenstrom's macroglobulinemia or lymphoplasmacytic lymphoma and a markedly elevated IgM. She had plasmapheresis instituted and then chemotherapy, and she did very well and was also able to be discharged. So hyperviscosity can be either secondary to monoglan. In the malignant setting, the one I'm describing is monoclonal gammopathies, particularly in multiple myeloma or Waldenstrom's, as was in our case. So hyperviscosity can also occur in non-malignant conditions. It's very important to recognize it early and think of it early because it's a fairly rare diagnosis. So it's a triad of bleeding, CNS symptoms, which can be just as subtle as a headache, but it's important to recognize it, and visual disturbances, later leading to complications such as loss of vision. You can get heart failure in these patients. You can get severe pulmonary symptoms. So it's quite important to recognize this early because there is an effective treatment. If you can see, just the background is the sausage-shaped capillaries of hyperviscosity. It's quite important to look in the eyes in these patients, and you do actually see these changes. The previous patient did have that. So again, just a quick approach to the management. If you have the clinical evidence of hyperviscosity, obviously, unfortunately, we don't have access to viscosity testing in our lab or in a clinical diagnosis. It's important to initiate plasma exchange therapy or get the patient to a center where this can occur. And initiate combination immunotherapy in the case of Waldenstrom's or appropriate chemotherapy in the case of myeloma. Other principles we can just use while you're trying to get the patient to a place with therapeutic plasma exchange is basically trying to avoid giving them blood products wherever possible, avoiding diuresis, IV fluids, and trying to basically give them use phlebotomy or venesection as well. That can also be instituted if appropriate as a holding strategy before you can use plasma exchange. So leukostasis and hyperleukocytosis, this is commonly seen in our hematological malignancies, ALL, AML, APML, which has a bit of a different approach. And these are, they can be quite devastating as well. These need emergent therapy. They're predictive tumor lysis. So if your patient has this condition, they're at very high risk for complications down the line as well. It's very important to use IV fluids and initiate chemotherapy in these patients quite quickly as appropriate. So the pathophysiology is related to actual plugging of vessels and hypoxia, local hypoxia of vessels, especially with the high metabolic rate of these dividing blasts and the cytokine production, endothelial damage, and subsequent hemorrhage. So essentially, the management of these patients focuses on trying to prevent the complications and recognizing and treating any complications there may be. As it's shown in the diagram, it occurs if you have a very high white cell count in your AML or your ALL. Leukapheresis is not really advocated because in acute promyelocytic leukemia, we would give the patient ATRA quite quickly, and then that could lead to the other complication being the ATRA syndrome, which we will discuss later on in the talk. So it's basically supportive therapy and initiating your chemotherapy and using leukapheresis in this case. So hypercalcemic malignancy, I'll touch on very briefly. Like I said, each of these topics is a talk on its own. I think this is the one that most people are very familiar with. Most of us have seen it. There's multiple mechanisms of humoral calcemia of malignancy. Parathyroid-related protein being the one that's most commonly implicated. Any cancer can do it as well, but breast cancer being common, your squamous cell cancers, be it lung, esophagus, cervix, are very commonly associated, and lymphoma, particularly your T-cell lymphomas, being quite commonly associated. Of interest, actually, parathyroid-related peptide is also implicated in the actual pathogenesis of the tumor and increasing proliferation and angiogenesis in the tumors. So the treatment, I think we're all quite familiar with this, but obviously it's to aggressively hydrate your patient using principle, monitoring the urine output, monitoring the calcium levels, and then going in a stepwise fashion as the patient wants, obviously monitoring the patient's response to therapy. We would give bisphosphonates as well if renal function allows, saline diuresis with furosemide, glucocorticoids are also part of the management. And eventually, if you're still not winning with all of these measures, you would then go to dialysis. So visceral crisis, just briefly, it's something we find in oncology. It does tend to occur with our advanced cancers, particularly advanced breast cancer. That's where the definition comes from. It's a severe organ dysfunction, which has severe symptoms and rapid disease progression, which we can only really assess by lab values. So it's not just the presence of having mets in your liver or your lung. It's associated with a poor outcome, but again, it depends on the patient, and it doesn't really preclude treating the patient So it's the ABC, so the Advanced Breast Cancer 5 consensus, which provides us a definition of visceral mets, where you have visceral crisis of the liver or visceral crisis of the lung, when you have the patient with a very high AST, with high bilis, or with dyspnea at rest, which cannot be alleviated by pleural drainage. So chemotherapy-related side effects. Again, this is not an exhaustive list. It can be related to the therapy directly, side effects of the therapy. You can get an anaphylactic reaction when you're receiving the therapy, and the effects of the therapy on the cancer, such as with tumor lysis syndrome. So this is just a little diagram to your acute complications of chemotherapy, your chronic complications of chemotherapy. It's really quite, unfortunately, our cytotoxic therapy can really knock patients. You can get anything up to cardiomyopathies, ototoxicity, peripheral neuropathies, severe mucositis. You can alopecia, which is obviously quite distressing to patients, but shouldn't lead to an admission, we would hope. And it's an opportunistic infections. So it's not an exhaustive list of symptoms, but can very important to recognize. So I just wanted to mention something about the checkpoint inhibitors. So this is new therapy, which is emerging for many cancers, going to become first line for many cancers, related to the upregulation of the immune system and the PDL1, so the persistent cell death ligands and proteins, which actually function to keep the immune system in check. So now we are actually upregulating the immune system with this therapy. The agents you may hear about are pembrolizumab, nivolumab. They come in the first world, it's already standard of care. It's also available in private. In the state sector, we have access to these drugs on a trial basis. So these are definitely complications that can end you up in the ICU or the critical care unit. Quite important to recognize. Pneumonitis, myocarditis, hypophysitis causing an adrenal crisis, multiple. So these are very potent drugs. They treat cancer very well, but they are associated with multiple side effects as well. Mucositis, I just wanted to mention something quickly on it because it is something that patients will commonly present with, and they can be quite sick. They can, even to the extent that patients can die due to mucositis, because it now provides a portal to entry of bacteria or pathogens into the system, and can be very distressing for the patient, up into the fact that they can maybe not even be able to eat and be in severe pain, and also essentially dehydrated from the mucositis. It's commonly seen with drugs such as high-dose methotrexate or use conditioning therapy, but it's multiple of the chemotherapy agents can give you mucositis. So specific malignancy-related emergencies, which I'm going to just discuss related to the therapy: choriocarcinoma syndrome, Atra syndrome. So just a brief word on choriocarcinoma syndrome. It's a rare but life-threatening condition. It's a bit of a misnomer because it often occurs with testicular germ cell tumors, where you have widespread tumors especially lung metastases, that when you treat the patient, they actually transiently will get much worse. So you might want to consider modulating your first chemotherapy regimen to avoid that in patients who have risk factors for this. So a very high beta-HCG or high tumor markers and a high burden of disease. Atrial syndrome is related to acute promyelocytic leukemia. As we know, acute promyelocytic leukemia is a maturation arrest of the promyelocytes, and we give the retinoic acid therapy in order to induce maturation in these cells. So as we mentioned before, leukostasis can occur, hypoleukocytosis can occur, and now we're actually inducing differentiation in these cells. We're making the cells plug up these capillaries, a high white cell count being a risk factor for this. So essentially, you would treat these patients with steroids, and you have to have a very, prevention is always better than a cure. You have to have a very high index of suspicion, because it can look like the patient has just gotten sepsis or worsened DIC from their primary malignancy. Again, this is just to show the pathophysiology, that the differentiated cells then adhere to the endothelium and extravasate, causing a very typical ARDS-like picture. A very, very important topic, neutropenic fever syndromes. Again, a talk on its own. There's multiple syndromes. It's associated with chemotherapy, iatrogenic, high mortality rates in these patients. We have to recognize this early. So it's basically the presence of a low neutrophil count with confirmed fever. So you can either have a spectrum from fever to septic shock, a documented microbiological infection, or so-called culture negative sepsis with fever without isolating a pathogen. So the risk factors obviously being your malignancy, your leukemias, the use of alemtuzumab, which is a T-cell depleting agent. Uncontrolled cancer is also a risk factor, and receiving cytotoxic therapy, which is myelosuppressive. And most induction regimens for our leukemias and acute and some of our solid organ malignancies are also quite myelosuppressive. That's one of the limiting toxicities of chemotherapy, myelosuppression. So it is unfortunately occurs common. We try to prevent it by giving patients GCSF support, but sometimes they do present with these emergencies. Like I mentioned, the high risk of death, they need to be risk stratified. So they're not your normal patient that you're going to have a fever, they're going to have a low blood pressure, you have some time to act, give them fluid, get them. No, these patients deteriorate very, very quickly, especially if they have a gram-negative pathogen, and they need emergency management. Preferably, they should be in a high dependency setting. In the developed world, there's leukemia units. We're very lucky in our setting as well that we have a very low threshold for ICU admission, and our ICU is very supportive, but obviously that doesn't occur in every setting. So it's important that they functionally have no immune system, because without your neutrophils, you have a very poor response to infection, and they can deteriorate very quickly. So just a quick approach to the patient. Obviously, you have to have a targeted history, but you need a physical examination with an emphasis on atypical sites. So they can get infections anywhere. They can have mucositis, the perianal region. You have to examine the abdomen very carefully for neutropenic enterocolitis, and obviously image appropriately. So diarrhea, you might consider CT abdo a bit quicker than you would with another patient. So you have to have a very targeted approach in these patients. You obviously need to culture them extensively, and you have to try and identify a pathogen. And if you're obviously getting features of septic shock, you have to escalate care appropriately, because this is an iatrogenic complication most of the time. So we have to really try and treat these patients aggressively. So the management principles, again, atypical sites, indwelling lines are very important. In oncology, we often place indwelling catheters such as ports or Hickman lines, and these can also become a source of infection. A directed approach to imaging, cultures. So it is controversial whether or not to give GCSF support in neutropenic sepsis or neutropenic shock. It's not going to change the natural outcome of your disease, but we see it in oncology as product support, the same way you would transfuse a patient. It shortens the duration of the neutropenia, which obviously would help your patient outcome. It would pathophysiologically help the patient. but hasn't been associated with better outcomes if you have a neutrophil reconstitution in septic shock. You would also get, unfortunately, your atypical organisms in these patients. Your fungi are very important. They're associated with the worst outcome. You've got to know your local antibiotic profile and microbiology. It is important to use empiric therapy. So if you even suspect neutropenic sepsis, institute the antimicrobial therapy. De-escalation is, again, a controversial issue, and it depends on your patient. Usually guidelines say that you should wait for the patient to have an absolute neutrophil count greater than 1 before you stop therapy. But there's no good evidence in this. So you really need to take an individual approach. If you've identified a pathogen, obviously paying attention to your antimicrobial stewardship principles as well. They're also at very high risk for multi-drug resistant organisms, because these patients have been in the hospital for a long time. They've probably gotten antimicrobial therapy at some point in the course of the illness as well. So the risk factors for poor outcome is having a pulmonary source. That's probably due to the fact that when they do very poorly, you intubate them. Fungal sepsis, multi-organ failure, which is self-inflammatory, and infection with the CRE or polymicrobial infection. So the tumor lysis syndrome, very quickly as well, is another complication of the therapy we give the patient. It can occur spontaneously, very rarely. There's a large burden of the tumor in terms of cancer-related risk factors, neoplastic infiltration of the bone marrow, bulky disease, a high mitotic rate of the tumor. We commonly see it in the heme malignancies, ALL, CML, but it can occur theoretically in any malignancy. Your non-Hodgkin's lymphoma, your Burkitt's lymphomas, even breast. We have seen occasionally in breast with very bulky disease and a highly proliferative tumor. And obviously, if you have pre-existing risk factors, such as something going on with your kidneys, receiving nephrotoxins like nephrotoxic chemotherapy, and being very sick and dehydrated, vomiting. We use a Cairo-Bishop classification, which is here on the side, to actually diagnose it. So it's a biochemical diagnosis of hypocalcemia being your first risk factor or your first clue, as well as a high LDH level. So the pathophysiology is related to the release of this, as the tumor cells lyse, they release DNA, which is what we call a damage-associated molecular protein, which starts your immune cascade off in your patient, relating then to the manifestations that we see in these patients. So basically, you're going to get a urate or calcium phosphate product precipitating in your kidneys, and that's obviously going to be a vicious cycle, worsening your renal failure. In the first world, we have access to rasburicase, which then converts uric acid to allantoin. It's a great agent, but unfortunately, we don't have access to it in South Africa, and we rely on allopurinol, where we're able to give it in terms of renal dysfunction, and obviously IV fluids. Recognizing that this patient is going to get tumor lysis is very important. Risk stratifying your patient, IV fluids with output monitoring, and early dialysis and involving the renal team. It's better to recognize it early, prevent it. If you suspect the patient, obviously do the blood tests and involve the renal team very early in these patient management. So just a brief note on ICU and the oncology patient. So the death of oncology patients in ICU is usually determined by the number of the organ failures they have and how quickly organ failures are reversed. So this is similar to other conditions, actually. Of note, especially in the neutropenic sepsis patient, intubation is related to a very poor prognosis in these patients. They tend to do worse. But contrary to popular opinion that cancer patients are going to always do worse than other patients, they actually don't when the cancer is treated appropriately. Obviously, if you have somebody with an untreated cancer, a pancreatic malignancy in a 90-year-old, we're not saying that you should consult ICU for such a patient. You need to look at your patient. So you need to have similar score. So we look at the same kind of similar scoring systems, such as the Apache-2 or the severity indices that we look at with other patients, and they have similar risk factors as well. So usually it's something like an acute organ failure that's going to precipitate your admission, be it status epilepticus or acute respiratory failure, neutropenic sepsis. The problem with what leads to mortality in these patients is delaying ICU admission. So when you wait too long to call the ICU or get the patient to ICU, that's when you unfortunately do worse. So there's some unique issues with patients with oncological patients in the ICU. Ventilation, as you mentioned, is associated with a worse outcome. And they're really highly complex patients, so they need really a multidisciplinary approach. And they're not, again, the normal patient, as we alluded to, in terms of antimicrobial stewardship principles, especially in the neutropenic setting. You need early admission before the patient manifests these life-threatening features. So if you have the neutropenic patient in the ward and the patient's not looking great, they're becoming a bit confused, call ICU now before you get the cascade of hypotension and you have to intubate the patient. There's no point calling when the patient's gasping. Nobody's going to be able to reverse that. So rather call early and be overly cautious than not. I think that is the message that we need to get across. And we have to intervene early on these patients to improve their outcomes. Like even with a malignant airway compression, you don't want to wait till the airway is completely obstructed and then try and get a tube in. It's obviously not going to work. So you've got to intervene and call for help early. So very important as well is communicating with the family and the patient themselves if you're able to. So it's a very frightening time for the patient and the family. The patients tend to have a lot of expectations. When they hear that they're going to get chemotherapy, they tend to associate it with a cure. If they also, now we've escalated their care to an intensive care unit, they also tend to think that the patient should have a good outcome. Some of these patients tend to be quite young as well, especially our leukemias, etc. And you have to then be very open and honest with these patients about what's going on and their prognosis, and have probably daily, even more, even more frequent discussions with the patient family and the patient themselves if they're able to. And you obviously have to allow them time to process what's going on. It's highly complicated for the doctor. Imagine for the patient and their family. You've got to answer their questions. You should allow, where appropriate and able, allow the family access to the patient as well. And you've got to have an MTT approach, as we've mentioned, including palliative care. It's very appropriate to involve palliative care in the discussions around these patients, and even decide if escalating care is appropriate or it may not be. So it's important, and there is a role for supportive care, managing a patient's pain and their distress. So it's a very important part of the management of an emergency is communication. So again, it's a ticking time bomb. As I say, there isn't really much time most of the time. You should try to make things happen urgently for patients with an emergency. I know it seems like an obvious thing to say, but in practice, in clinical practice, we often find that that doesn't happen. Obviously, this is also related to resources. We have to be appropriate with that and keep that in mind as well. But wherever possible, we'd like to refer to a high dependency unit early and appropriately refer to your appropriate specialties early. Please consult oncology if you're not sure. If you're not sure about the diagnosis, what therapy the patient has been on, that we're very happy to give advice. If you're not sure about what the prognosis of the cancer is, you're struggling with the diagnosis, please call for help. And remember that it's a special patient subset. They don't deteriorate the same way. They're very sick. They're very complex. So you need to call for help if it's needed. So just in conclusion, this is a really massive topic. I've tried my best in the allocated time to kind of get through the main points, and just I've given a very, very brief overview. I haven't even scratched the surface. So just you're welcome to read around these topics and use this as a jumping off point. I've just tried to give a general approach. And even what I've said in this talk is likely to change and evolve in terms of therapies going forward. Oncology progresses at a rapid rate. So there may be new therapies that we get that are actually less toxic or even more toxic. So we'll have to see going forward. Important to remember, ask for help, get an MDT involving many people as appropriate, an MDT approach, and very important to follow the principles. So histological diagnosis, staging, grading, very important, and obviously your goals of what you're trying to achieve with your therapy. It's just a little reminder and my references. Thank you.